The topic that I'm going to discuss today is pathophysiology of delirium, and it's actually going to be a two-part series. I'm going to do part one, and Dr. Mark Antonio is going to touch on the same topic with a different flavor tomorrow. So we'll try and cover various aspects of the pathophysiology of delirium, mechanism of delirium within these two talks. Quick thing about disclosure, I have a research grant from Hospira, which provides study drug for my R01 funded MENS 2 study, which is a randomized controlled trial of dexmedetomidine versus propofol. So study is supported by the NIH, but study drug does come from Hospira. With regards to the talk today, the focus is going to be on prevalent pathophysiological models. I'm going to provide you all with a broad overview. So we're not going to be delving into the nitty-gritty of each and every model that's out there. I'll try and focus on the critically ill patients. So I'm not saying just ICU patients, but patients who are sick and come to our hospital and in the ICU. So that's a broad range of critically ill patients. And I'm going to try and provide you all with some evidence, at least supportive, that we have from human studies that show that there may be some rationale for why we are looking at these mechanisms as mechanisms for delirium. So not just that somebody thought about it and wrote a nice review article about it, or that there are distant sort of basic science models, but at least some integration with human studies. As a broad sort of objective of this talk, we're going to go over these different mechanisms. Can you guys see it with the light, or do we need to adjust the lights over here? Okay. So we're going to talk about neurotransmitters, neuronal aging, inflammation and coagulation, endothelial dysfunction, the neuroendocrine hypothesis, role of oxidative stress, and then network connectivity. And the last one of network connectivity, I'm just going to briefly mention. It's a very dense topic. I'm no expert in that area, so I'm going to just briefly mention it to you, give you all some references, and let you all read about it in detail later on. Okay. Now, recently, Dr. Maldonado tried to put some of these models together to try and say, how is it that these may play together? So realize that all these pathophysiological models don't occur in isolation. It's not that just one model gets perturbed, but that these models all work together, or these mechanisms all work together to have potentially an outcome of delirium at the back end. And so what this model says is that you have a precipitant of delirium. So you may have an older patient. You may have a patient with some amount of cognitive decline. You may have a patient who then has sepsis, etc. So you have a precipitant of delirium, and that results in either, over a period of time, you have neuronal aging that kicks in, you have neuroinflammation, oxidative stress, some neuroendocrine dysregulation, you may have some circadian disturbances. All these then perhaps play a role in the neurotransmitter dysregulation, some amount of network disconnectivity, and then overall the system just fails. So trying to get all these different models perhaps acting together, some elements versus the other, higher versus lower, resulting in this disintegration at the back end. So let's start delving into each of these models into a little bit more detail. So thinking about the neurotransmitter model and the imbalances over there, the first thing I'm going to talk about is this neuroamine axis hypothesis. And the important thing to realize over here is that some of these neurotransmitters, such as dopamine, serotonin, norepinephrine, have been associated with delirium. So higher levels of these neurotransmitters being associated with delirium. Now, the precursor amino acids do play a role, because the precursor amino acids are actually the rate-limiting step for some of these neurotransmitter synthesis. And they fight at the level of the LAT1 transporters in the blood-brain barrier to make it through into the central nervous system. So if you look at the precursors, tryptophan being a precursor of serotonin, tyrosine or phenylalanine being a precursor of dopamine and norepinephrine. So with these perturbations of the amino acids, you may have corresponding changes at the level of the neurotransmitters, because they are finally competing against each other to get through the LAT1 transporter. Now looking at some of the human studies associated with tryptophan, etc., that's an area that has been studied quite a bit, and at least some work done by Tom Robinson initially and others have shown that maybe tryptophan depletion is associated with delirium. And so a number of studies, whether you're looking at low levels of tryptophan, looking at some large amino acid changes over here, again, which levels increase, and higher levels of tryptophan versus lower levels of tryptophan being associated with normal versus more risk for delirium. Now, where does all this play in? Why is it that tryptophan may play a role? And so some of the thoughts on this, again, are if you have tryptophan and the levels are high, you may end up with greater amount of serotonin, potentially leading to greater melatonin, more somnolence, perhaps linked to hypoactive delirium. On the other hand, if you have low levels of tryptophan, you may result in going through this alternative pathway, and some of these products that are associated with the alternative pathway resulting in more excitation and hyperactive delirium. Now, while tryptophan may play a role, there are metabolites of tryptophan that are also neuroexcitatory. And the important thing to realize is that while most of us are concerned about tryptophan going down the serotonin pathway, when you have patients with sepsis in high inflammatory states, when you have acidosis, etc., tryptophan, actually majority of it gets metabolized through this other pathway, which leads to kynurenine. And then in kynurenine, once you get to kynurenine, again, if you are in a state of inflammation, you go down this pathway with quinolinic acid and neurotoxic effect, versus if you are relatively normal, you go down kynurenic acid, and this has neuroprotective effect. So kynurenine is another area that has been explored, and we have looked at this in our group, that whether high levels of kynurenine are associated with worse outcomes, perhaps going down through this pathway. These metabolites cannot be easily measured in humans, so kynurenine becomes one of the surrogate measures for assessing for delirium. And in this study, this was a study of about 130 patients that we did at Vandy, and looking at the levels of kynurenine. And if you have higher levels of kynurenine, as shown on the x-axis over here, you had fewer days without delirium and coma. So you would prefer to have fewer days without delirium coma. So this is days without delirium and coma. And as your days go higher, or as your kynurenine level goes higher, your days without delirium and coma reduce. Okay? So high levels of kynurenine being associated with worse outcomes. So that's kynurenine, tryptophan sort of playing a role in some of those neurotransmitters. Acetylcholine is another neurotransmitter that has got quite a bit of association with delirium, and the thought being that low levels of acetylcholine associated with delirium. Now, the cholinergic pathway has important roles both for arousal and attention and for memory and cognition. So it does play a role in pathways or with features that are commonly seen with delirium. When they've done neuroimaging studies to look at cholinergic pathways and where people have neuroimaging lesions when patients have delirium, what has been seen is that there is a fair amount of overlap. So in this figure, everything that is in these gray, dark gray circles are neuroimaging lesions that have been seen in patients with delirium. This is a summative figure, not on an individual patient. So areas that commonly seem to be implicated are the prefrontal cortex, the parietal lobe, thalamus and hippocampus over here, some elements of the temporal lobe. So you can see a large number of these gray circles showing that those areas are implicated in patients with delirium. These lighter gray areas over here are centers of attention. And you can see the projections, these arrows over here are cholinergic projections, and you can see a fair amount of cholinergic projections overlapped with these areas that you have either lesions already being seen in neuroimaging studies or lesions that are involved in attention. So a fair amount of overlap over there. And again, number of studies done in humans looking at the level of anticholinergic medications, etc., associated with delirium. So studies which show that, yes, there may be a mechanistic pathway. And again, when you look at human studies measuring the levels of acetylcholine through some surrogate associations with delirium. All right, moving on to neuronal aging, and this is going to be a sort of brief overview of these other mechanisms. What do you see with aging? You see a diminished physiological reserve. You see some elements of changes in your stress-regulating neurotransmitters. There's blood flow problems, the endothelial dysfunction associated with aging. There's neuronal loss, so actually atrophy, and there's some elements of decreased signaling between various areas in the brain. This is a study that we did a number of years ago looking at risk factors for delirium, and there are numerous other studies which have shown the same thing, that as you age, your risk factors or your risk for delirium goes higher. And in this study in particular, by the time you get to the 60, 65 years of age, you can see a relatively sharp probability of going to delirium when you are in the ICU. Sort of stable in the mid-40s, 30s, but then a sharp rise at 70. So association between aging and then delirium. Now, simultaneous with aging is atrophy. And so there are studies which have looked at brain atrophy and its association with delirium. These are data from the VISION study. This was about 50 patients who were critically ill, then recovered, so survived, and were then taken to an MRI scanner at discharge and at 3 months. And what we were looking at was an association between the duration of delirium that they had with atrophy. Now, the important thing to realize in ICU studies is you don't know which one came first. We know when the delirium came, but the atrophy we were measuring at discharge. We did not have any of this measured prior to their critical illness because we didn't know they were going to get sick. So these are patients who were in the ICU at discharge, and at 3 months we measured the cerebral volumes. And in particular, I want to focus on hippocampus and the superior frontal lobe. So in this figure, the top part figure is for hippocampus, the lower portion is for the superior frontal lobe. The x-axis over here is days of delirium, y-axis is volume. And if you just look at the top part over here, at discharge and at 3 months, if you had greater days of delirium as shown in the x-axis, you had decreased volumes in the hippocampal area and in the superior frontal lobe. So not just a global atrophy, but specific decreases in volume with longer durations of delirium in the superior frontal lobe, which is associated with attention, executive function, as well as with the hippocampus, which is associated with memory. So aligned with some of the things that we actually see in patients with delirium, you had targeted volume loss in those areas. Now, which one came first? One doesn't know. Whether they had atrophy, because this is an older population, they had atrophy, so higher link with delirium, or it was the other way around, that they had longer durations of delirium and then had subsequent atrophy. There are other studies which have shown that atrophy can begin really quickly. So it's not improbable that somebody had delirium and had the atrophy within the 2 to 3 months that they were followed up with, though it's likely that it could have preceded the delirium as well. Moving on to neuroinflammation, and again, greater details, we may go into biomarkers in greater details tomorrow. I'm just going to touch on the overall principle of how systemic and neuroinflammation may be tied together. So this is a slide that many people have seen before, and what it shows is that if you have systemic inflammation and endothelial dysfunction, what that might result in is elevated cytokine levels. So over here, you may not be able to see it, but it's TNF alpha. You have increased TNF alpha, which now makes it across the blood-brain barrier into the brain. You can get some elements of microglial activation. Now, the role of astrocytes are also being evaluated with studies showing increased S100B, some studies showing BDNF, and there's some element of astrocyte and BDNF together that might play a role in delirium. Now, in many patients, you have a cholinergic inhibition of this microglial activity. So if your cholinergic system is working fine, this inflammation that you might have will get dampened down, and patients might have a short duration of delirium, not a very severe form of delirium, and they might get better. On the other hand, you may have a scenario where your patient is older, has prior cognitive decline. So these folks actually have primed microglia already. They have some element of neuroinflammation already going on. And so then when they have a systemic inflammation, you end again with some element of neuroinflammation, except that you now have primed microglia to begin with. That results in a significantly higher level of overactive microglia. Now, in older patients, in patients who are on anticholinergic medications, that cholinergic inhibition may not occur as well as the previous group, which did not have those problems. And as a result of that, you then result in a significantly higher element of overactive microglia, and that results in more severe delirium or prolonged delirium, etc. So having a baseline vulnerability added to the systemic inflammation might result in worse outcomes because they're already primed to have some issues going on from that standpoint. Now, the endothelium as such is being studied. It's a large part of our body, and so specifically also playing a role in the blood-brain barrier. And the role of endothelial dysfunction and neurological injury have been evaluated in numerous studies recently. The hypothesis over here is that you have endothelial dysfunction that might result in impaired perfusion. Impaired perfusion, this is central nervous system, increased permeability, and therefore you may end up with further toxin exposure. A lot of things that should not go through your blood-brain barrier actually go through into the central nervous system, resulting in neuronal damage, and then the circle sort of goes on. Now, we've looked at these in numerous ways. We've measured it with what's called the Endopath device, which measures vascular reactivity and is a measure of endothelial health. And what we found was that if you have increased endopath reactivity index, so higher numbers are is better. So you want to have lower numbers are better. So if you have adjusted days of delirium, greater adjusted days of delirium, when you have, I keep flipping this around, I'm sorry, greater adjusted days of delirium when you have a lower endopath. As your endopath number increases, so you have better reactivity, your adjusted days of delirium decrease. So it's a way that you can measure this peripherally. Now, I'm sorry that this figure is so garish and bright red. This is not how we submitted it to the journal. They decided on the color combination, and we only saw it at the proof stage, and we were told that that is not debatable as to what color they were going to choose. So we never had these red confidence interval bands on it. We would never do such a thing, but no choice. The next one, and so we've got 7 models. We'll get to number 5, is the neuroendocrine hypothesis. And what this basically says is that in stages of stress, your HPA axis is the one that gets activated, and you have high levels of cortisol. So you have high levels of cortisol that get secreted when you are in a period of stress. And that those high levels of cortisol can result in a number of sort of bad outcomes. It is protective, but in normal humans, when they get better, that cortisol level should drop back to normal. Now, if it does not, and those cortisol receptors continue to be fired, you may have increased reactive oxygen species, resulting in cell death. You might have some element of neuronal and synaptic atrophy. You might have some cytokine and release, etc., some neuroinflammation, and resulting in worse outcomes. What is important to realize is that the highest amount of glucocorticoid receptors are in the hippocampus. So again, an area that is associated heavily with delirium, being associated with high levels of glucocorticoid receptors. And if those glucocorticoid receptors continue to get stimulated because of either an aberrancy in the response, you might have delirium from that standpoint. And again, studies which have shown cortisol levels being associated with delirium. So this is one study where I'm just showing you, looking at postoperative delirium and high levels of cortisol as shown over here. Where is it gone? Preoperative cortisol being associated with a significant p-value, high odds ratio associated with delirium. Similarly, a study which was done in the ICU by Dane Leadham's group showing that high levels of cortisol being associated with delirium. Now, the flip side of it is cortisol level or cortisol or corticosteroids have been given in many patient populations, and in some studies it has actually been shown to be associated with lower delirium. So that those things don't gel together. And this is one study. So this was the HYPRESS randomized study where they were looking at the effect of hydrocortisone on the development of shock. What they found was that in the group that was placebo versus hydrocortisone, if you look at delirium, and it's buried somewhere down here, where did it go? It's way at the bottom, sorry. So you can see 24% in the group that was in the placebo group and 11% in the group that got hydrocortisone. So there is also some thought that it may be the type of the steroid which might matter in this case, where the mineralocorticoid activity, glucocorticoid activity, and at least some review articles that Dale Needham has written potentially talk about those, that there may be a differential effect of the type of steroids on delirium. Now, oxidative stress is another area that is being explored. And the model over here is that you have some element of decreased cerebral perfusion, you have ischemia, and that ischemia results in either excitotoxicity through glutamate, you might result in some apoptosis, and then again linked with inflammation. So again, these things don't occur in isolation, they all occur together. Now, whether you have oxidative stress from just ischemia or from hyperoxia, it's actually being debated, because earlier work was all talking about ischemia and hypoxia, that if you have ischemia and hypoxia, you end up with having worse outcomes. Newer studies are now looking at the role of hyperoxia as well as reperfusion after an area of, or time of ischemia. And we've actually studied this in a large cohort of cardiac surgical patients, and the results were actually quite interesting. I'm going to try and walk you all through this. The purple, I don't know how it's projecting over there. The purple is hyperoxic reperfusion. That means you had a period of time, about 20 minutes, below a threshold where you were having ischemia. This is after cardiac surgery, and then severe hyperoxia. So that's reperfusion. This is pure hyperoxia. You never had hypoxia, but in the operating room, we put people on 100% FiO2, and you have a significant increase in your cerebral oximetry as compared to baseline. Or the third group was just hypoxia. And what we found was the odds of having delirium were highest in the group that had hyperoxic reperfusion. So people who had hypoxia and then were being given oxygen, etc., had this hyperperfusion after that, those groups had a higher odds of having delirium than the group that had just hypoxia or just hyperoxia. Okay? So at least looking at that, hyperoxic reperfusion might be associated with worse outcomes. Now, in this study, we actually measured levels of oxidative damage through using isofurans and isoprostanes, and we measured them both at baseline and after this period that they had when they arrived in the ICU. And what we found was that the baseline levels did not matter, but if you had higher levels of isofurans or isoprostanes in the ICU, that was associated with greater delirium. And those are markers or oxidative stress. When we've done mediation analysis in these studies, what we found was that some of the hyperoxia and hyperoxic reperfusion mediates its effect through the release of these oxidative stress biomarkers. So there may be a role where hyperoxia or hyperoxic reperfusion results in oxidative damage through some of these molecules, resulting in delirium. And the last one over here is the system network connectivity model. And this really talks about the brain being highly organized and interconnected. I don't think any of us will doubt that part. And that when there is a breakdown in this high systemic integration, that's when you result in having problems. And that if you have precipitant factors such as age or prior cognitive impairment, some of those networks are already broken, potentially resulting in you having a higher odds of having delirium after you then have a stressor. Now, this is work done by Arjen Sluter's group, and they've done a fair amount of work in this area. There are other groups that have been working in this, but I've just put up one slide, and you all can look at this slide. This was in anesthesiology a couple of years ago, and what they were looking at was using patients who were having cardiac surgery, having EEG monitors in them, and trying to see where there was any gap, first of all, where there were EEG signal problems, and whether there was any connectivity issues. Okay? What they found was that delirium was associated with a decrease in alpha power and increase in delta power. This is something that has been quite regularly published now, that at least these two areas are areas that you may want to focus when you're looking at EEGs in delirium. They then wanted to look at something called phase lag index. And what that shows is the synchronicity between two areas within a particular band. So if you're looking at the alpha band or the delta band, you're trying to see the phase lag between one point and the second point. How quickly does information get transferred versus how slow it gets transferred, and that looks at connectivity from that standpoint. And what they found was that within the alpha band, that connectivity or that transfer of information was much slower in the group that had delirium versus the group that did not have delirium. So some decrease in the alpha power, but also the connectivity within the alpha band being significantly decreased. Now, in the delta band, there actually was an increase, but it was an increase in sort of some of the posterior lobes of the brain versus the anterior. And what they found was in normal humans, the gradient is from anterior to posterior, and in delirium group, the gradient was from posterior to anterior. So some connectivity loss, but also gradient loss. Now, when you give a normal human propofol or sedation, the anterior to posterior connections are slowed down. So there's so that also shows that there is, in delirium, it works the other way around. That signaling is not normal, and it perhaps is going, the gradient is in the wrong way as compared to the way it's seen in normal humans. Now again, this is really a dense topic. This is the simplest thing that I can tell you all about it. We've looked at some of these connectivities in a larger scale, with not looking at individual pieces, but trying to see whether there are areas of brain where connectivity is lost when you look at patients with delirium and without delirium. So this is the same study which I've shown you data on the hippocampal volume loss as well as the superior frontal volume loss. And what we were looking at was functional anisotropy, looking at how water flows through sort of axons in the large white matter tract. And the goal for the functional anisotropy is that you want most of the water, that's how it's measured, going through those tracts so that it's closer to 1. If you have leaks or white matter connectivity is not adequate, those numbers decrease because water is lost and not going along the tract. So lower functional anisotropy associated with worse connectivity. And what we showed over here was if you had greater duration of delirium, you had much lower fractional anisotropy, so much lower than 1 when you were looking at the anterior limb of the internal capsule, whether you look at it at discharge or at 3 months. And similarly, in the genu of the corpus callosum, as your days of delirium increase, as shown on the x-axis, your fractional anisotropy also decreases. So greater days of delirium associated with less intact white matter tracts. So I'm going to end by saying that, again, there are a number of hypotheses out there. They all are probably integrated in some way or the other together. None of these work in isolation. At the moment, at least, there's been a fair amount of focus on neuronal aging, on neurotransmitters, that oxidative stress might play a role, that you may have some element of neuroendocrine problems, all of those sort of playing a role in some elements of either having a precipitant and then further having some elements of neuronal connectivity loss, all leading to sort of systemic failure at the central nervous system and leading to delirium. Thank you.
We do have at least 5 minutes for questions. Thank you. The hypothesis, like the various hypotheses suggest that delirium is a singular entity, right? That there is a final common path to reach. And I just wondered about we were talking last night a little bit about the differences between kind of lumping things into delirium versus splitting into various subtypes, not just motoric.
I actually feel that these represent that it's not a single common path. Yeah, the single common pathway is that the system fails in the end. That's the single common pathway. But I don't think I'm saying that there is one single thing at the back end. So all these various things, so you could come into delirium through any of these pathways. Either you have precipitant factors such as aging, and that results in neurotransmitter imbalances. So I actually do not think that there's a single common pathway, and that at least thus far, every time we've tried to think about it that way and try to modulate it, so cholinergic pathway, try and modulate it, give them rivastigmine, you result in worse outcomes. We've tried that with steroids. While one study may have shown benefits, other studies have not. There have been now 2 or 3 studies which have looked at statins, whether statins work on endothelial function, statins work on trying to reduce neuroinflammation or inflammation in general through all its pleiotropic effects. No difference in outcomes. There is the prevention studies that Vanderbilt showed with haloperidol trying to affect dopamine levels through preventive use of haloperidol for delirium, no impact on outcomes. So I don't really think there is a single common pathway.
Yeah, maybe I just wondering where should we be looking at different outcomes and not just delirium as a singular group, I guess, as the outcome then? Should we be looking at different kind of symptom types or?
Yeah, I do think so. So ultimately, I think as we try and figure out mechanisms and as we try and figure out treatments, it probably is worthwhile trying to determine singular groups. The question is whether those exist or whether there's a fair amount of overlap. If you look at some work that Tim Gerard and Wes, we just published on delirium subtypes, there's so much overlap. How do you find a septic delirious patient who is not on sedative and who perhaps is not hypoxic? It's just so difficult. And so there may be some studies which looked at trying to create some clusters and starting to break it up. Instead of this entire thing lumped together, instead of splitting it into individual things, you might find some clusters that we can at least start working on. Sorry, that was a long answer. I may have used up my 5 minutes, but go ahead.
We're going to use the mic before recording. Thank you.
Oh, sure. Just, I have two questions, but the first one was that the EndoPat device, so that looks at peripheral endothelial reactivity. And that's interesting to me that we think that that would be a good representative model of cerebral endothelial activity, since there's obviously very different mechanisms for autoregulation in the brain with both metabolic and pressure autoregulation.
I think it's a surrogate marker of overall endothelial health. And so it's been correlated with even with sort of cardiac function. It's been correlated now with studies where we've taken mammary arteries while having cardiac bypass and associated with the endopath, showing a correlation between that. So I don't think it's a marker. I think it's a marker of generalized endothelial health more than just something over here. And the way it's done is you have, while you're measuring reactivity on one hand, your other hand becomes the control. So therefore, other elements such as these patients are on vasopressors, how does that impact? Well, it impacts both hands equally, so therefore those things get factored into this measurement. So I still feel that it's a marker of just global endothelial health more than just a local vascular effect.
Okay.
Not convinced, I know, but
No, it's
that's the
just
best I
because
can tell.
the metabolic autoregulation of the brain is just such a strong driver to endothelial reactivity that it surprises me, but obviously
But
it shows associated.
again, it's not in isolation, right? So you may have endothelial health, and then you may have disturbed autoregulation on top of it, and you may have neuroinflammation on top of it. And so what you're saying is that at least your baseline endothelial health is also associated with worse outcomes, and then that might be just one of the precipitants.
And then real quick also, for the MRI study looking at the white matter and the water transmission through white matter, why did you look at the anterior limb of the internal capsule? Those are motor fibers, so it surprises me that it would have anything. Was that just found, or was that a specific area that you chose to look at beforehand?
Those were sort of, in the literature, again, those are large areas that have been shown to be associated with delirium.
Just because it's a large white
Ye-
matter
yes.
tract that's easily identified.
Correct.
I understand.
Yeah.
Okay.
All right. Thank you. Oh, one more, sorry.
Basically looking at major highways.
Yeah.
Hi. Considering this complex scenario, what's your take on biomarkers, and do you think are there any promising biomarkers for delirium?
I'm going to let Dr. Marcantonio talk about that. He has a full hour to discuss that tomorrow. I think there are a few promising biomarkers, but again, it's the same issue I have, is that none of these biomarkers work in isolation. So what we've been able to show is biomarkers of inflammation associated with delirium, biomarkers of endothelial health, whether you're looking at PI1, you're looking at E-selectin, etc., associated with delirium. So all these have been shown to be associated with delirium, but all have been done relatively in isolation. And how one biomarker interacts with the other biomarker so that we can actually get maybe a complex array of biomarkers which have high specificity and sensitivity. I don't think we're there yet. So association studies have been done, but I'm not sure we can say that if you do the 6 panel and this interacts with this and this interacts with this, therefore we know that we can get to a high probability of suspecting delirium, and we're not there yet. All right, great, thank you.